Welcome to Complicating the Narrative, a podcast that takes on the challenging questions in public health by embracing complexity rather than avoiding it. I'm your host, Salma Abdallah. In the United States and across much of the world, we are becoming a population where nearly as many people are over 65 years old as there are children, making aging one of the most defining features of public health in this century. Today, we're examining an important question about aging in America. How do we create environments where people can live the lives they want as they age? The vast majority of older adults in the US want to age in their own homes, but only 1 in 10 homes can safely support aging with dignity. Falls, which are largely preventable, consume about 9% of Medicaid budget, which is roughly about $80 billion annually. My guest today is Dr. Susy Stark, a professor at Washington University in St. Louis School of Public Health. Susy has spent decades thinking about how our physical environments either enable or constrain what's possible as we age. She developed the Home Hazard Removal Program and other interventions to address the needs of older adults in their home environments. Susy's work anchors ease of implementation and personal experiences in how we design for aging. Susy, welcome to the podcast.
Thank you. Glad to be here.
I wanted to start first of all, just a disclaimer that I saw you talk, and then I thought, I think way more people need to listen to this. First, maybe talk us through why did you think it's important to think about aging in the United States? What drew you to thinking about what type of environments that older people need to have in their homes to be able to live and age with dignity?
Sure. So I'm an occupational therapist by training. And so before I became a researcher, I was really interested in providing optimal care. My very first job, actually, before I was an OT, was as a nurse's aide. And I spent many hours with older adults who had often been abandoned by family members to kind of live out their last years in a nursing home or an institutionalized setting. And it was painful to see the loss that people felt personally, kind of emotionally as they lived out their final years. And eventually, many of them died alone in these kinds of settings. And as I became a therapist, no one ever said to me, "Hey, Susie, get me to that nursing home." Everybody always told me they wanted to go home. But we were working in clinics and we weren't really paying attention to what was happening in people's homes. So I started taking a peek at what was inside people's homes to see what might support them or prevent them from living out their best lives in the places where they wanted to age in place. And it became so clear to me that there were such easy, simple things that we could do to modify people's homes to help them stay independent, stay where they wanted to be with the families and the memories that surrounded them in their later years that were so important. So that became my life's work. And that's what I'm really committed to, is fixing not the person, because older adults, often we can't fix them anymore to improve their function, but we can change the context that they live in to make it possible for them to be as independent as possible.
Yeah.
That's my story.
And I think you start, I've looked at this presentation as I mentioned earlier, but also others. And I think you always start with describing the context of having more older adults.
Yes.
You usually, I think, use the description of we're moving from an aging pyramid to an aging column. So can you explain to us what does that mean for people who are not demographers or maybe don't know about the demographics of the country?
Yes. So we are undergoing a pretty significant demographic shift. I am one of the oldest Gen Xers. I was born in 1966. And I describe my life as always feeling like a big party just left. So that meant the baby boomers were this gigantic generation of children that we'd never seen before, who just took up so many resources and so much space in our society. We never had such a large demographic kind of cohort like the baby boomers. Well, those baby boomers are now aging in place. So they are now the folks that are actually in need of the services, the kinds of services that I have. And all of these baby boomers have lived pretty healthy lives in general. So they're living much longer than previous cohorts of older adults lived. So that means we've gone from having a few older adults in our society supported by many younger people, working age and younger people, to having almost as many older adults as we have everyone else. Older adults are overtaking the younger generation now. So instead of an aging pyramid, we now have an aging column, which has some pretty significant implications for society. I always like to feel good about helping people age in place where they want to live, but it's become kind of a big policy issue for our society. We do not have the resources in terms of aging providers or even institutions to provide support for that large number of older adults. We are actually at a place in our society where we're going to need to make sure that older adults can live as long as possible in their private homes, just in order to make our healthcare and societal systems work.
And I think it's interesting what you said earlier about how people tell you, I want to go home. And then if I remember correctly from your presentation, only 1 in 10 homes are actually equipped for people who are older adults to live in, versus about
Well,
89% of them want to go back home.
yeah,
Yeah.
AARP does a survey every year, and every
Yeah.
year older adults say, I'm going to stay at home and age in place. But you're right. You're absolutely right. Only 1 in 10 homes have the kinds of modifications that older adults need.
Yeah.
So it's interesting that most older adults live in private homes, and most older adults live in the same home for more than 25 years. So the house that you buy when you're 35 is probably not the house that you're going to need to support your abilities when you're 80 or 90, or maybe you've had your hip replaced. So slippery bathtubs, lack of lighting, stairs without handrails, those are the kinds of things that we're seeing in homes of older adults who are now in their 75, 80 years of age. And those are the kinds of homes that lead to terrible consequences. When that person doesn't match, their abilities don't match the homes that they have, we have a risk for things like falls. That's the other passionate thing I want to talk about today is
Yeah.
the risk of having a fall is very, very high when we have a misfit between a person's body and the home they're trying to live in.
It actually read my mind, because my next question was going to be, so what is the problem of having homes? I mean, understandably, it's part of it is people being able to get around their home, but I think the other risk is exactly what you talked about, which is the risk of falling. And honestly, again, you are one of the few resources that I've seen, or earlier resources that I've seen, that educated me about risks of falling, especially among older adults. So do you want to tell us a bit about that?
So falls, we put the risk of falls into 3 big buckets. And the first risk is kind of the intrinsic or abilities of the person. So that bucket would be things like your strength or your ability to balance yourself. It could be things like your sensation. So maybe some people might lose sensory ability in their toes. They can't really tell where their feet are when they're putting them down. Things we all undergo: loss of vision, so different aging related changes associated with vision could make it really hard for your eyes to adjust in dark spaces. Losing your hearing, actually not getting your hearing tested, can actually be a risk of falling. Being 80 years old is a risk of falling. Being female is a risk of falling. Some of the things we can't do anything about. But those abilities, those clusters of abilities we have, then interact with the environment. So tubs that are slippery, that don't have anything to stop you from slipping, not having anything to hold on to when you're getting off the toilet, lack of handrails, those are environmental factors.
Yeah.
Then the third bucket, the one that we all can do something about, but rarely do we do it, is our behavior.
Yeah.
Rushing, not paying attention, drinking lots of alcohol when maybe we shouldn't. Those are all things that kind of come together and often interact with each other that lead to a risk of falling.
So then what happens? Why is falling bad? If I'm an older adult, could I fall and just shake it off and get up? What happens next?
So it's pretty stunning. I actually started studying falls after one of my community partners asked me to give a talk about falls. And I did not realize the negative consequences of falls. I guess I did because I was seeing people who were being treated in rehab after a fall. But I didn't put all these things together and think about the potential that we had for preventing falls. But falls are the leading cause of injury for older adults. So hip fractures, leading cause of brain injury, leading cause of premature institutionalization, if you want to think about that. So the consequences of falls are pretty serious. They can lead to an increased fear of falling. And
Mm.
guess what? Having a fear of falling is a risk of falling.
Wow. Yeah.
Having a fall puts you at twice the risk of having another fall. All of these consequences of falls are mighty impactful. The one that I find sad is that I think it's every 11 seconds an older adult is being transferred to the emergency department. That's pretty expensive.
Yeah.
If you want to think about every 20 minutes, an older adult is dying from the consequences of falls. For those who are more concerned about healthcare policy, it's stunning to me that the cost of non-fatal falls, so if you survive a fall, the costs this year are $80 billion annually. This is up from 50 billion in 2015. That is a function of both the increased number of falls that are happening because of the growing population, but also I think we haven't done a great job of reducing the rate of falls.
Yeah.
I just saw numbers recently. The consequences of falls are consuming 9% of the Medicare budget,
Wow.
9% of that budget, which seems like a significant amount. And I think I want to just say one thing. Maybe you're going to ask me this, but falls are preventable. We can actually
Yeah.
do something about it.
Yeah.
But as a society, we don't.
Yeah. I, I think that's a perfect segue then to me asking you about HARP, because I think that's what you are trying to do, is thinking about how do we prevent falls. And you thought about this program. Can you just walk us through what HARP is and where did that idea come from? So I know you're passionate about falls. You've seen people in physical therapy, and you're also passionate about addressing the challenges that older adults have. So how does that all ended up with you focusing on HARP?
Yeah, so I study the environment, and I'm really interested in kind of how we can support older adults aging in place. That's always been what I'm interested in. And when you have older adults with chronic conditions and you have older adults, we tend to not see a big improvement in strength and balance and these things. We tend to see people lose function over time. We can compensate for function. If we can't improve it, we can compensate for it. And that's where the environment comes in. And so back to your point of 1 in 10 homes have changes that will support aging in place. I think it's really important to notice that about half of all falls occur in the home. So, and many of those falls are attributed to barriers in the home, like that I mentioned, slippery tubs, for example. So it seems to me like this is a really, really good potential place where we can intervene to stop a big number of falls. Now, falls are multifactorial, as we discussed, so we can't stop all the falls. We can't stop the fall at the grocery store if we're modifying the home, but we can stop a good portion of them if we help older adults by modifying the home. So that is why I became interested in it. We have the tools at the ready. But there's some barriers too. So as OTs, we are all trained to provide home modifications, but we all practice in clinics, and it's really expensive for therapists to leave clinics and to go into people's homes to make modifications. So I developed this program based on really good therapy to try to demonstrate that it would be cost effective and impactful in reducing the number of falls if we delivered programs like this. We know how to do it. It just doesn't happen as part of healthcare as we know it today.
And that's important, right? Because I read the article, the JAMA article that you have, and we would link to in the notes for this podcast, that it seems like the similar work has been done in Australia and in the European Union, but it doesn't seem like it was translated into the United States. So do you know why? What was the barrier? Is that just like it hasn't been done yet?
So I think the barrier is that we are not really good at looking at community-based care in the US. We have a really fragmented system. So the occupational therapists that know how to deliver this care are not practicing in the community very often. They're kind of tucked away in hospitals and clinics in the hospitals. And really, we know that the older adults need these therapists helping them in the home, because to have a good intervention, it's actually kind of like personalized medicine. It's personalized fall prevention. It doesn't do any good to go into somebody's home and put up 30 grab bars if they don't need a grab bar.
Yeah.
Maybe their problem was vision, and you need to add lighting. So we have to actually see the person's home. When you've seen one older adult's home, you've seen one older adult's home. So we can't predict. look at the individual profile of abilities and risk factors that that older adult has and their behaviors, the things that they want to do, the activities that they participate in their homes, kind of take all of those elements into consideration and come up with an individualized plan to reduce each person's unique fall risks in their home. The other thing we know that has to happen, we know this from our colleagues in Europe and Australia, as you've mentioned, is we have to help older adults deliver this, put this intervention in place. We
Yeah.
cannot just say, here's a list of 50 things you can do in your home. Good luck. We actually have to help them. You know, it's hard when you're 85 to figure out how to get a contractor in to put in grab bars. We have to help them and make sure that's put in place and that they know how to use everything safely before we walk out. That's the secret sauce to making a good quality of intervention to remove hazards in the home for older adults.
So just from a methodological point of view, so people understand, you created a randomized trial, a
Mhm.
pragmatic randomized trial to look into the implementation of HARP. And I think, again, it's a really useful way to think about those type of interventions and whether they work or not. And people who are interested in the methods can look into them in the paper. But what was really fascinating to me, I think, and really made your point come across, at least in the talk, was the examples that you've used. So can you just walk us through them, thinking about what happens when someone enrolled in the treatment group? So they actually got HARP. Especially, it would be really helpful if you have examples. I know when you had visuals, that was very great, but I don't know if you can also tell us, using just audio without having the
Yeah,
images, good examples. That would be very helpful.
sure.
Yeah.
So let's say you were enrolled in our study, or let's say you were somebody that was going to get HARP. The first thing that happens is a therapist comes into your home and we evaluate all of those abilities that I talked about, your vision, all that stuff. So we have a really good sense of what your strengths and your limitations are from that assessment. And then we start walking through your home with you. And we try to make sure we want a lot of self management to happen from this. It's not just that the therapist solves the barrier that day, but what about the barrier tomorrow when your cat is laying flat across the walkway?
Yeah.
We want you to be able to identify barriers yourself. So we actually do a lot of teaching people to manage their own risks at home. So as we're walking and talking and identifying barriers for older adults, we're having them help us identify barriers too, so they become really good therapists for themselves. And then we will, the thing that we do that's different than what a lot of folks do is we do a lot of shared decision making. So
Huh.
we will say the person will help us identify a barrier is that a toilet seat might be too low. My grandmother used to say this all the time. I don't know why those toilets keep shrinking every year. It's harder and harder to get off the toilets, right? So we'll talk about the barrier is the toilet is really low. Well, there's a lot of different ways to increase the height of a toilet. So then we will talk through and we will show images of potential strategies to that person. So one way to increase the height of a toilet to make it easier to get off if you've lost strength in your thighs is that we might ask people we can say we can add something to the top of your toilet. So it's a little ring that you drop on your toilet. It's kind of ugly. Sometimes it's hard to clean, but it makes it so easy to get off the toilet. The strengths of this are you can pick up that ring and take it with you wherever you want to go. If you're visiting your sister-in-law or if you're going to your home in Florida, that ring can travel with you, but it increases the height of the toilet. So suddenly you can get off it on your own.
Yeah.
We also might be able to add a new toilet. So it might cost a little more, but everybody talks about the toilets that they're using at fast food restaurants that might be 19 inches tall instead of a home version that's 16 inches. But boy, those are a lot easier to get off, right? So we could just replace the whole darn toilet. I've had one woman who had a blue toilet that matched her blue sink that didn't want to change her toilet because Robin's Egg blue toilets are hard to find these days. But we could lift the toilet up and put a little spacer underneath the toilet so that the toilet would be a little bit higher, still be the Robin's Egg blue toilet. So those are the kinds of conversations that we have, and those are the ways that we solve barriers. And that's important because that gets buy-in from the older adult, so they are on board with and decide what the modifications are for themselves. So that's one of the things we do. Lots of things that we do are very unique, but some of the most common things we add are handrails. So lots of railings by the toilet, by the shower, up and down the stairs. Sometimes coming in from the garage, there might not be a handrail. So places like that that will add railings and something to hold on to. We
Yeah.
also do a lot of no stick or sticky kind of no skid tape in places like stairways and in bathtubs so people don't slip. Places you're going to slip, we'll make sure you don't slip. My favorite is I call it the runway, all the way from the bed to the bathroom. We can put these really cool little lights on people's hallways that
Hmm.
are on a motion sensor. So if you get up to go to the bathroom, there's an airplane strip lit up that you can use to get to the bathroom safely. So those are the kinds of things that we often deploy for reducing barriers in the home.
Some of things that once you hear them, they're very obvious, but it was what was really fascinating for me is, but they're only obvious because your team took the time to just sit around and see how does the person use their home and then identifying those areas. So it's like a lot of really good ideas. They seem obvious after they happen, but I think the idea of just sitting there and seeing how the person lives in their environment, I think is very helpful. So what did you guys find?
Believe me, it was not obvious to me when we started that we should make sure we understand how people use their homes and make sure that people got to pick the way that we change their
Hmm.
home. That took a lot of figuring out. You're right. It's so obvious. We should have known. We should have been client centered to start with. But those are
Yeah.
important elements that I think are important to mention because I don't see them offered in a lot of programs and they are critical for the success of ours.
Hmm.
And when you do this intervention in the way that we've laid it out, we can get a 38% reduction in the rate of falls for older
Okay.
adults. So it's not perfect. We haven't reduced it by 100%. But like I said, we can't prevent people from falling at the grocery store or on a nice sidewalk. But at home, we were able, by changing the home, we were able to reduce the overall fall rate by 38%.
Hmm.
What was important too, I think, is we had an 111% return on investment. So for every dollar that we spent, we had a couple dollars and some change in healthcare savings reduction. So,
Yeah.
a reduction in the number of times that you have to go to the emergency room or see a doctor or see a therapist because of the consequences of experiencing a fall, I think have big implications for our future healthcare system when we're thinking about ways that we can reduce Medicare spending, and I'm looking at that 9% of the Medicare budget, I think understanding that little tiny changes in this very small place in the world can potentially yield some significant dollars.
I'm pretty sure policymakers like hearing those type of numbers. So, which brings me then to the next point, which I'm really fascinated by. As people know who listen to this, I'm someone who's deeply interested in how we translate research into policy, or how do we influence policy. You did actually manage to work with the National Council on Aging when it comes to updating some of the guidelines on what needs to be done for to reduce the rates of falls among older adults. So what happened there, and what type of recommendations do they have now?
Right. So I'm a community engaged scientist, which means I work my close community partner. I don't work in a hospital system. I work in what's called an area agency on aging. So the St.
Yeah.
Louis Area Agency on Aging touches about 10,000 older adults annually. And mostly they're well known for providing home delivered meals for people who are at a nutrition desk. But a lot of people don't realize that the Older Americans Act, which funds area agencies on aging in every county in every state in the US. So it's a national network of aging providers, not commonly associated with the healthcare providers.
Mm.
But we liked this potential group because they touch older adults that don't get seen by the healthcare system, who might be out at risk on their own. And folks that need help with getting a meal are our target market, high
Yeah.
risk older adults who are pretty frail. So we started with that group and they felt it was very important that we take our intervention and get it approved by the National Council on Aging as an evidence-based intervention because that unlocks access to dollars that every AAA has to spend on
Yeah.
evidence-based intervention. So Suddenly, if you're approved by the NCOA as an evidence-based intervention, the area agencies on aging across the US are able to spend money on providing HARP for older adults that might not get access to it otherwise.
Yeah.
So we love our community partners. And so we skeptically put it through this rigorous review process. We had to have an implementation study. We had to have a bunch of work behind it, not just one RCT, but one strong RCT, a randomized clinical trial. And it was reviewed by peers, like a peer review process to determine if it met the qualifications for an evidence-based intervention. It did. And so now the NCOA is able to offer it. It can be used in different resources that the Older Americans Act provides, whereas just saying we want to do home modifications wouldn't have qualified. But if we do home modifications in this way, using this evidence-based intervention, it does give all of these community agencies access to dollars to provide the service, which is really important.
So then, maybe on a separate but relevant note, what did you learn from trying to influence policy?
Well, I've learned that policy's slow. And I mean, honestly, I got my PhD and started this exact line of inquiry because as a therapist, I called an insurance company to get pre-approval to put a bath bench in for one of my patients that had sustained a hip fracture. And she was not able to get into her bathtub because of her hip fracture, because of the precautions that she had related to that. But all I needed to do was buy this $200 bathtub bench that she could have just slid into her tub and taken a bath on her own. And when I met her, she was getting a bath aide to come in 3 times a week to help with her self-care. Those are the days. I don't think anybody would get a bath aide 3 days a week anymore. But she was costing the system a lot of money. And I called and I was so bright-eyed and bushy-tailed. And I said, this is great. I'm going to save you so much money. Just buy me this bathtub bench and I will have her independent and not needing this bath aid by the end of the week. And they said, yeah, we're not going to pay for that. That's not a covered service. We don't pay for modifications like that
Oh,
as part of health insurance.
yeah.
And I said, why? And they said, well, there's no evidence for that. So that started me down my pathway
Yeah.
of, well, I'm going to give you the evidence to show
Yeah.
you that this is going to really impact your bottom line. But yet it's really slow. Medicare is still, it's not. So some of the advantage programs are now starting to provide interventions like this and to provide modifications, but it's been a real slog to get this approved across the board for all Medicare beneficiaries. It's not part of standard of care yet, which has been painful to watch. We've gotten the evidence now, and we're doing our best to advocate. But it's advocating on a lot of different levels. So I've met a lot of really lovely elected officials who are behind this. Most of whom have had family members who've had falls and are really passionate about this. But in the system that we have not quite gotten to the point where this is standard of care that everybody can expect.
So then maybe pivoting to something that you referenced multiple times today, and I think in your talk as well, that you are a community-based researcher. I think that the principle you operate from is nothing about us without us.
Right.
And maybe can you expand a bit on that, especially when it comes to this type of work? And I'll just put my cards on the table here. As someone who my grandmother, who's an elder, went through falls and her case deteriorated, and am I going through that with my mother now as she gets slightly older? I find it very hard to convince anyone who's older that there needs to be some modifications. But it seems like not only have you cracked the puzzle on how to get them engaged with your work, but also to help to actually get them, at least from your talk, to get them be part of how do you talk to students, how do you talk to other stakeholders. So how did you figure that out?
So first, I'm really sorry to hear about your family. I hope there comes a day when I don't hear as many stories as I do, and I know it's really hard. But to answer your question, one of the great joys of my job was I like hanging out with older adults. That's why I became a therapist. And it seemed really logical to me to bring them along in our studies. So everything I've tried out, all of the interventions have been with the support of the community partners I have, the people that provide service, because I need to understand how what we do will fit in the context of what's offered. But then what's going to work? The only fall I've ever had for any of my interventions was an older adult who was putting her throw rug back down after the nice therapist left because she didn't want her to know that she disagreed with her
Huh.
intervention. So stories like that early on in my career showed me that I needed to meet people where they were, and understand their lives in order to make effective interventions. So that's why we take the extra time to figure out what kind of intervention people will accept. So we have a very, very high adherence rate. When you make the decision yourself to employ some of these changes, it's a lot easier to accept them and use them permanently. It's also my great joy once I try to make sure that I teach people principles of support in the
Hmm.
home, that I see them going ahead and making more changes for themselves to make themselves safer. As I check back in with them, there's more modifications often there than when I left because they keep working to keep themselves safe. And I couldn't have designed an intervention that would be that, I guess, durable without the support of all the older adults that I work with.
Hmm.
So yes, they teach with me. I feel like my graduate students learn so much more when the older adults critique their posters and their presentations than when I do. They help us develop new interventions. They make sure that we think carefully about recruitment. They make sure I'm very careful about ethics and inclusion of people. We have long, hard conversations about a lot of things. They also teach everybody how to do a good interview with an older adult. They practice with us. They're pretty amazing humans that are so altruistic and believe so passionately in what we do and try to make sure we do a really good job making sure they're safe.
And I think another thing that you do as well, in addition to just really being fully community based, is you showed a photo of one of your advisors or one of the people who you worked with that made you realize you should start with implementation science in mind. So, how did that change the structure of the research that you did? When you think about implementation science as you're designing an RCT, what would that look like?
It really was design. Call it designing for implementation. So I try to take it from the perspective of the therapist, the intervention, the older adults, the providers, and we backed it all up to imagine what would make an intervention that everybody could deploy quickly, easily, effectively, efficiently. How could we design the intervention to work with practice and to be appealing to older adults? So it's the questions like that that helped us, I think, design an intervention that was palatable, not just by our community partners, but also by the older adults themselves. Those are the questions that we really think about when we're designing an intervention that we hope will last.
Yeah.
Because as we know, it is really, really hard to get uptake of new interventions. If it was easy, everybody would be exercising and eating healthy meals and complying with all medications, and we're not. And
Yeah.
so, what are the barriers that prevent us from taking on these changes, these behavioral changes or these health changes? Is what we really tried to look at from the beginning, which I think helped us quite a bit.
So before we end on our two last questions, I would be remiss not to bring my structural lens to this. So I really love, as I said, what you're working on, and I think it is helpful for people to talk more about falls. But I think the person who's screaming at the top of my head saying, "Why can't we change policies to make sure that homes are built in a way that are really in agreement with someone who's an older adult who wants to live in a dignified way in their own home? Like, why can't we start with interventions at that level?" What would you say to something like that?
I um I really love that idea. It's harder in the US to make those things happen.
Yeah.
We are kind of all, every man for themselves. We are, you're not going to tell me what to do kind of
Yeah.
society. But even the societies that have more I would say, accessible guidelines as part of housing, which seems normal to me, right?
Yeah.
We're all required to have heating and cooling and plumbing and electrical guidelines. Why can't we make guidelines so that there's always an exit and entrance for fires if somebody needs to get out of their home?
Yeah.
If they're, why can't we make it so the first floor has a bathroom so that people that are coming home post stroke have a place to sleep until they're able to go back up to their master bedroom on the second
Yeah.
floor? I don't know the answer to that. I know that other communities across the world have made that part of their standard kind of guidelines for how homes are developed. We have not gotten there. I
Yeah.
will say, little pockets. There are little pockets of places in the US where we might have what we call visitability requirements or universal
Mm.
design. But those tend to be very specific to municipalities across the US, nothing that's kind of a blanket
Mm.
policy that you require. Now we do have those for commercial spaces, but not for private homes. So I would
Yeah.
love to see it, but I would caution you, even the work that I do in accessible apartments,
Yeah.
still sometimes we need to modify things a little bit. That precision medicine thing that I
Yeah.
talked about, there are
Yeah.
still little tweaks that people will need to keep themselves safe. So I think it will get us, you know, 40% closer to where we need to be.
Yeah.
But we need to keep in mind that everybody needs an individual approach.
Because as you said earlier, if you've seen one older adult in their house, you've seen one older adult in their house. Can I actually ask, before we go to a few final questions, how easy is it to get in rental homes? How easy is it to get the modifications that you need? Do you find that, especially in rental homes, landlords are open to some of the modifications that you're suggesting?
So, funny enough, older
Mm.
adults are fantastic folks to rent your homes. They're quiet, they stay for a long time. And I've had mostly good luck with landlords who I would say, I'll pay for this modification, or the older adult will, and we can leave it there for you. And then it's a benefit to the next person. Legally, the person might be required to remove the modification if the landlord wanted to. But most landlords today have realized that it's a value add to their property. And so we've had landlords embrace the idea of making modifications. Folks that rent homes, it's a lot of work to turn your home over. So if you could keep an older adult as a tenant for a few more years by adding a grab bar, I found that they're very willing to do this.
So then, ending hopefully on a high note, if you're talking to younger researchers who are thinking about working on aging or just in an issue that they're very passionate about, and they see that there might be a solution, but for some reason the policy is not being implemented there, what would you say to them? Again, just to be completely honest with you, I think we had two conversations that I thought were very helpful. First one was because you're working on aging, it seemed to me like you realize that you need to be a generalist in working on different areas or different topics, given the type of funding that the US provides. But the second one, I think we were talking about an issue, and you did mention to me that for a while you were working with a team of people, maybe at a hospital, and then you realized that maybe we work with other group because you're not asking the same questions. Like also identifying who are the groups that you need to work with, depending on like what type of question you're actually trying to answer. That is, and everyone might be working on a different part of the issue, but if you're not looking for the same people who are trying to find the same similar answers to the same question, that might also create some issues of friction. Yeah.
Absolutely. What I would say to students is, number one, this is one of those big, hairy problems. And
Yeah.
aging requires my favorite team sport, which is team science. So understanding who can come to the table to help you solve the problems is going to give you a huge leg up. I love working with big teams, whether it's, a primary care physician, a geriatrician, a nurse. I work with contractors, I work with social workers and, agency providers. And I love that. I think that not assuming that you have to do this all yourself, but knowing that you can kind of rely on your team members to brainstorm and problem solve is super fun to me. So I would say to students, use your teams and use your team skills. And then other other issue I think I would tell students is, wow, I think if you wanted to think about one of the big problems of our society, aging is one. And if we don't address aging, I think we are going to have some significant consequences as a society that we haven't even begun to think about yet. So wow, what an impactful career you can have. And if you're kind of cynical, I would say job security, because there's such a high need for folks to work in the aging field that you will always have an opportunity for a position. So my most cynical self says, aging, yay, you have a job. My most optimistic self says, wow, what an impact you can have.
Yeah.
But the other thing that I like students to think about is we often get into this us versus them, older adults and me. I'm 21 years old, just starting out in the world. But I quickly realized that what I'm working on in my career is going to help me age successfully. So it's not us and them. This is all for us. This is all going to help us live our best lives. And so what a great way to spend your career.
So then our last question here is, what would be a narrative, because this is called complicating the narrative after all, about aging, about falls, about prevention or independence that you think needs more complicating in our conversations, especially in public health?
I think the thing that we need to talk about more is how we are all going to come together to support older adults. I feel like when we leave people out to manage their mom on their own, it becomes really it's really hard and painful and isolating. But if we all start to work together to solve these problems, if we can support each other, and by that I mean, supporting folks in the workplace that need to go take care of their parents so that they can keep them safe and independent. Learning how to advocate on behalf of ourselves and our family members who are older so that we can help them stay safe longer. I think we have isolated older adult care into little tiny buckets, and that's preventing this holistic approach to helping people stay independent and safe longer. I'll just share one little snippet of what stunned me when I realized we were all working together. I was working on a fall prevention intervention for people who were undergoing surgery. And one of the risks of falls is taking 4 or more medications. And specifically taking medications like maybe Benadryl or Ambien that might make you as an older adult at a higher risk of falls. Things that might have been recommended by your physician early in your life that you're now 75 and still taking. And I looked at the physician who was an anesthesiologist, and I said, of course, you take care of all these medications that are inappropriate before someone goes in for surgery, right? In this pre-surgery clinic. And the physician said, of course not. I would never touch what another physician recommended. And I said, even though you know this is putting them at risk for a very likely risk of falls post-surgery, even though. And I thought, why can't we all just work together? Why are we in these little tiny buckets doing our best to protect ourselves when what we really need to do is take a holistic view and kind of look at the complicated situation that is each older adult? So that's where I think we need to complicate the narrative. We need to look at aging holistically. We need to think about our families and ourselves and how it's going to help us.
I think that story, especially from my time in medicine, clearly highlights why we definitely need to think more about holistic approaches to aging and other issues. I think people now think, oh, holistic approach, that's a truism. Of course we do it, but I don't really think we do. Susy, thank you so much for joining us today.
Thank you so much for letting me talk about this. I love getting this out there. I really appreciate it.
This episode was edited by Catalina Melendez-Contreras with marketing and outreach by Kinkini Bahaduri. The podcast is supported by the School of Public Health and the Frick Initiative at Washington University in St. Louis. You can find Complicating the Narrative wherever you get your podcast, and you can also watch the episodes on YouTube. If you found this conversation useful, rating, sharing, or recommending the podcast is one of the best ways to help us reach more people. Thank you for listening.